are visible.
Sure. Good evening, everybody. Welcome to the 19th fellowship course by the ECMO Society of India. So now you can hardly see the patient, the sick patient. You have so many gadgets here. And we know we do ECMO for heart or lung failure. And the kidneys, obviously, as expected, is one of the first organs to also get hit. And you do need some form of renal replacement therapy in most of our patients. So no disclosures. And I call this the Jugalbandi, ECMO and CRRT. These are two big maestros helping save a patient's life. So the incidence of acute kidney injury in patients on ECMO is anywhere from 26 to 85%. The sicker the patient, the more the risk. And the need for renal replacement therapy is about 50%. And they usually require it during the first week of ECMO if they are not on it already. And for obvious reasons, because of hypoperfusion, AKI is more common in VA than VV ECMO, and it is multifactorial, the etiology. The ELSO data, the need for renal replacement in respiratory indications is about 29%. And for cardiac indications, renal replacement therapy, so in cardiac ECMO, basically, it's pretty much the same. So the mechanism of acute kidney injury on ECMO. So patient factors, we know these are the sickest of sick patients. So they already have hypoperfusion. That's why they went on ECMO. There's loss of autoregulation, reperfusion injury, especially after they go on ECMO. And then from low SATs, you have high SATs, from hypotension. In fact, we often encounter hypertension in our VV ECMO patients. Then the high ventilatory pressures, the hypercapnia, acidosis, which can cause RV dysfunction and back pressure into the kidneys, the biotrauma because of high ventilatory pressure, renal congestion, which can also be contributed by intra-abdominal hypertension, organ crosstalk, hypercoagulable state can also cause some renal thrombosis, the comorbidities much more in adults, and fluid overload. Fluid overload. All these patients, before they go on ECMO, because of their hypotension, they get a lot of fluids. They get fluids when they go on ECMO. So fluid overload itself can cause a lot of renal congestion. Now, ECMO factors. ECMO itself can contribute to AKI. So because you all know now that there is loss of pulsatility in VA ECMO. And it is an artificial membrane. So the blood, there is a lot of, shear stress to the RBCs. There's complement activation, there's cytokines, leukocyte activation, hypercoagulability. Then there's hemolysis because of the RBCs get fractured, and hemolysis itself will contribute to your AKI. There's complement activation. And of course, it's more, all this is much more when there is, cannulae malposition, because then there's negative suck, and more the negative pressures, more the hemolysis. So, but what are the indications for renal replacement therapy on ECMO? So this was an international survey, and you will be surprised that it is not AKI that is the reason for renal replacement on ECMO. It is actually fluid overload and prevention of fluid overload. So why fluids are needed in ECMO? Pre-ECMO, because they're for shock. Even patients with ARDS who are very sick, warranting ECMO, do have hypotension because of RV dysfunction. It's like an acute cor pulmonale. So we have had patients who have come hypoxemic, hypercapnic on multiple inotropes. It's because of the RV that is failing. And the minute they are placed on VV ECMO, we have to rush to SNP for reducing their high blood pressures. So at initiation, there is vasodilatation, capillary leak. So you'll need a lot of blood products. The underlying disease itself, septic shock or dengue, pancreatitis, may need steady filling. And during ECMO, you need a lot of blood products, either for bleeding or to prevent bleeding or for chattering. That's one of the commonest indications. Every time there's chattering, we tend to give fluids at every shift. So fluid overload, we end up causing fluid overload in our ECMO patients, and there's a lot of capillary leak. And as you can see, this fluid overload itself can reduce your renal perfusion and cause AKI. So how do we have to be obsessive about this. We have to do intake output in every shift and look for cumulative fluid balance. And what is fluid overload? It's not just fluid balance. When you say fluid overload, it means there is something that is also it's bad. It's causing either pulmonary edema, peripheral edema, and we do calculate the percentage of fluid overload. And multiple studies in ECMO patients, non-ECMO patients have shown that a fluid overload of more than 10% has been associated with increased mortality. And how do you calculate? This is the formula: your cumulative intake minus output by the admission weight times 100. So this is another index for those who are not familiar. So it is not only a fluid balance. You can see A and B, the fluid balance is the same. But if you have a less intake and the balance is still considerable, that means a lot of fluid is being retained in the patient. There is capillary leak, and that is very concerning. So fluid balance in relation to your fluid intake makes a lot more sense than just looking at fluid balance alone. So here patient B is a lot worse than patient A, because patient B is getting less fluids, but most of it is, getting accumulated in the body. And ECMO patients, it has been shown that a positive fluid balance at ECMO day 3. So we all know first 48 hours, there's capillary leak, they'll need blood products and all. But even after day 3, they are still fluid overloaded. Then that's very worrying. So there is another study, even on VV ECMO. So VV ECMO patients do get a lot of fluids, but VV ECMO also, if you have got fluid overload, then there is negative survival. This is another study which showed that less than 10% at initiation had good outcomes, but if they remained positive, more than 10% fluid overload, even after decannulation, then the survival was very poor. Pediatric patients, non-survivors, had a higher fluid overload. So we know fluid overload is very bad, and we have to remove it, and we have to give diuretics or some form of renal replacement therapy. Now, AKI, what about AKI? The worse the stage of AKI, the worse the survival on ECMO. Another indication for renal replacement therapy on ECMO patients is poisonings, worse, very bad acidosis. So it need not be just, it could be, various indications why the patient went on ECMO. So the bad acidosis is one reason for initiating renal replacement therapy. Of course, the other fringe benefit is it also removes all your cytokines. Neonates, they are very, very sensitive to your maintenance fluid, to all the blood products that you give, and they tend to get fluid overload much earlier, neonates and infants. And by initiating early renal replacement therapy, you can actually give your nutrition, you can give, take care of all this as well, and remember that it is not only the fluid boluses that, cause fluid overload, it is also your maintenance fluids, your medications, the dilutions, etc., and all your infusions. So this is called the fluid creep. And neonates and infants, it can be a lot. So what are the factors of affecting survival on ECMO, patients with AKI, patients with fluid overload? Time to CRRT, does it make any difference? Well, it has to be individualized. There are no clear-cut guidelines to say that, it's this many hours. Renal function, remember, serum creatinine has a lag period, so you can't go based on serum creatinine. Fluid overload is actually the most sensitive index to decide when you have to go on renal replacement therapy. So earlier need not be better, but you'll have to individualize. And it should definitely be considered when fluid overload is stubborn, doesn't respond to diuretics, and there is acidosis, which is overwhelming the kidney's ability to compensate. Don't go by creatinine, because creatinine has a lag period of 48 hours. It needs 50% of drop in GFR, and fluid overload also dilutes your creatinine. So there is an adjusted creatinine, which takes into factor your cumulative balance in liters. What about the outcome of AKI? Does it mean that all patients who go on renal replacement therapy on ECMO will fare badly? No. Renal recovery is very good in those who have survived ECMO in pediatrics. In adults, if they required a renal replacement for more than 7 days, because of all the comorbidities, they may have a higher risk of end-stage renal disease, may have some ventilator dependence, and etc. So the ELSO, what does it say? They have emphasized the need for avoiding fluid overload and to return the extracellular volume to normal and drive it and maintain it there. So the message for you all fellows, please be very mindful of your response to all the chattering. Don't give knee-jerk fluid bolus for every chattering. Be mindful of all your dilution volumes in medications, antibiotics, your maintenance fluid. Start furosemide infusion after the first 48 hours if the patient is not in shock. Remember, you have instituted ECMO for hypoxemia in VV ECMO. And if you have fluid in the lungs, it defeats the very purpose of ECMO. So this is a very nice algorithm for chattering. Do fluid resuscitation only if you are very sure that the patient is hypovolemic or there is shock. What you could do is decrease the pump speed if there is chattering, check cannula position, speak to your surgeon, look for clots, and if need be, add a second drainage cannula. Now, fluid removal, what are the techniques? You can just put a hemofilter. This removes only fluid, but if you want to correct your acidosis, if you want to remove your cytokines, solutes, urea, correct your metabolic parameters, then you will need renal replacement therapy. You'll need the CRRT machine. This was a neonate whom we placed a meconium aspiration syndrome, who went on ECMO, and look at the amount of fluid in the subcutaneous as well as in the lungs. So this patient went on CRRT on the ECMO, and you can see the lungs also clear up and the subcutaneous, and this child could be weaned off ECMO and did very well. So this was a neonate. So what are the modalities that you can offer for renal replacement therapy in your patients? One is the simple scuff, that is just a hemofilter, which will remove only fluids. And then you have your renal RRT machine. You can do CVVH, CVVHD, CVVHDF. You all anyway will be familiar with these terminologies. When you say CVVHD, then it is only diffusive and it's smaller molecules. When you say CVVH or CVVHDF, you have convective clearance and you have a little, so diffusive is small molecules, convective is middle molecules, so a little more cytokines are also removed. So if you have a very sick patient, it would make sense to put CVV-HDF, which has both diffusive as well as convective clearance. So middle and small molecules are removed. IHT, you would not do it on ECMO because it causes rapid fluid removal. There's risk of hemodynamic instability, disequilibrium syndrome, and you will have so many connections, though it is low cost. Ideal would be your continuous renal replacement therapy, where you have a more precise control of your fluid balance in these sick, hemodynamically unstable patient, and it removes fluid and solute. Now, what if the patient cannot afford? You can put SLED on the ECMO, but run the SLED for a little longer time, maybe 12 hours, not the usual 6 hours. So this is the poor man's CRRT. It can be done, but there are disconnections every day because when you stop and start the SLED. PD, of course, you wouldn't want it in patients who are anticoagulated, and you cannot do it for long. Plus, there's risk of peritonitis. Now, there are two ways of connecting this machine, this big gizmo, into patients on ECMO. So either you can have a separate VASCAT and then connect it to the RRT, and then you have your ECMO circuit. You're not at all interfering with the ECMO circuit as well as the flows. But what does it mean, especially in small children? It means there's a lot of blood extracorporeal. There's some blood going into the ECMO, then there's blood going into your CRRT, and that can cause a lot of problems, a lot of clot. Plus, also vascular access. You now have no access for changing your central line. So this becomes a real problem. So ideal worldwide, what is used is connecting the CRRT into the ECMO circuit itself, not through a VASCAT into the patient. So this is called the series, as opposed to the parallel that I showed you. And this is a lot more easier. Of course, you have to ensure that all the connections are done by the perfusionist. And as Dr. Nanda was mentioning, be very, very careful, mindful of all your connections. Otherwise, you could have air going into the ECMO, and also clots could form. So you have to be really careful because there's going to be a lot more connections. There's definitely a little more risk of hemolysis in small children because this blood is going through so many connections. But it has been done, and this was the newborn patient who did very well. We just celebrated the first birthday last few months ago. And this, you can see the CRRT machine connected into the ECMO circuit. This was a child with meconium aspiration syndrome. One thing to remember in kids below 20 kilo, best to prime the machine with CRRT machine with blood, not with albumin or fluid, because otherwise it causes a lot of dilution of your platelets, etc. So it's better to prime with blood. and you need special filters in neonates. Now, fellows, you have to remember this. You have to understand the pressure differences in the ECMO circuit. So this is coming from the patient into the pump. So this entire patient to pump pressures are negative. That's how the pump sucks it from the patient. From the pump back to the patient, that is all through the oxygenator, etc. It's all positive. And how positive? You can see the difference. So negative pressure is anywhere from -20 to -100. So -100 is not a good sign because then you'll have more hemolysis. And then positive pressure is anywhere from +50, 350. So which means there's a lot of shear stress, and that's why you get a lot of hemolysis. So it depends where you connect your RRT machine into the circuit. Your pressures are also reflected into the CRRT machine and the filter. So where to connect? If you want to connect the CRRT access into the ECMO circuit, it can be anywhere, the access. But return, going back from the CRRT into the patient, into the ECMO circuit, should never be post-oxygenator, because then there's risk of air embolism. This is just a rule of thumb, and it's easy to remember. So what can you connect? I said you can just connect the hemofilter. So using the positive pressure. So I told you post-pump is all positive. So using the positive pressure in the ECMO circuit, you can drive in the blood into the hemofilter. You don't need a machine for this, so simple hemofilter. And then back, it goes into the negative side. It's very easy to, to pull out a lot of fluid for 6 hours, because the longevity of the filter is only that much. It's less precise ultrafiltration. You don't have any solute clearance. And you'll have to keep changing your filter every day. But it's very good for fluid removal. There's no need for any pressure monitoring. So in centrifugal pump, where is the access? It's as always good to take from the positive side, because you can use the high pressure of the ECMO circuit into the CRRT to drive blood into the CRRT. Remember, the flows in the CRRT are 1/10 of the flows in the ECMO circuit. So it's very minuscule if you compare the amount of blood that goes into the CRRT from the ECMO machine. In centrifugal pumps, access from the negative side into the CRRT can cause issues, because if you don't have very good flows and you're also taking blood into the CRRT from the negative side, that means your pre-pump pressures, then it can cause more air getting sucked in. Never return post-oxygenator, I've already mentioned. You don't need separate warmer. We all know when patients, especially pediatrics, are on CRRT, they get cold, but you don't need a separate warmer, because you have the warmer heater of the ECMO. You don't need separate anticoagulation as well, but you may need to increase your heparin dose to target a little higher ACT if there is risk for clots. Ensure CRRT connections are handled by perfusionist. So I will just take you through to the different connections that can be done and the rationale. So it can be taken from the negative. So you access into the RRT machine from the negative. So this is the patient to the pump. So that patient to the pump is always negative, as I said. So this is negative. So access is negative, goes to the RRT machine, and the return is also negative. There is a risk of air embolism, especially in the access side. Or you could take it from the positive, that is the post pump, where the pressures are higher, into the RRT machine, and then return it back to the negative side. Or it could be taken in between the pump and the oxygenator. So the access is also positive, return is also positive. Or the other option could be you are taking it post-oxygenator and returning it pre-oxygenator, which is also both positive. This is the technique that we follow in our hospital. Access is post-oxygenator, but we return it back to the negative. So it's a little more easier. So your filter longevity is, it's lasts a little longer, because it doesn't have to push against resistance. So whichever your perfusionist is comfortable with, any of these options can be used. Here the recirculation, even though it's oxygenated blood going back pre-pump, the recirculation is very negligible. This shunt is very small. Now you have to remember, I told you the ECMO pressures are much higher. So depending on where you connect, your access or drain return pressures could be positive or negative, and that will be reflected on your console. And depending on that, your filter pressures also. So you can say this is only a CRRT machine. Here, the CRRT machine is on the ECMO. Look at the filter pressures here, 292 as opposed to filter pressures of 105. So you'll have to monitor the TMP pressures in the CRRT as well. the filter pressures, not only in your ECMO circuit. And we all know that in the first 48 hours, even if you connect your RRT machine into the ECMO patients, you will not be able to remove fluids because they'll be in capillary leak, but at least you can avoid positive balance. So you can keep it zero balance. So to match the intake and the output, and you can very well control it on the CRRT. After 48 hours, no leaky, to get negative, you can start albumin. Remember, CRRT removes a lot of amino acids and phosphate, and that you'll have to replace. Now, I talked about all the pressure differences that will be demonstrated in your workshops, but depending on which alarm and where you connect, so your perfusionist may have to change the alarms. There'll be a low pressure alarm beeping if it's on the negative side of your ECMO circuit, high pressure alarm beeping if it's on the positive side. So air embolism, air entrapment, be very mindful during connecting, disconnecting. And if access is connected to the negative side of the centrifugal, there can be air entrapment. Hemolysis is expected, especially in pediatrics because of the small flows. Clotting, you have to closely watch when you connect your CRRT. And of course, filter failure, which you will have to replace. Pediatric considerations. Every 1% increase in fluid overload has a 3% increase in mortality. And remember, it's an adult machine, so you have to choose good filters. And there's a lot of volume lost, especially in small children outside the patient. It's extracorporeal. That's why we do blood priming of the circuit. And these are some numbers that you'll have to remember. The circuit volume should be less than 10% of estimated blood volume. This is the blood flow in infants and children. And this is the ultrafiltration rate, about 1 mils per kilo per hour. And you need special filters for less than 10 kilos and give amino acids and phosphate. If they are very acidotic, a new filter with AN69, you can have bradykinin release. You can drop your blood pressures. And we circumvent this by giving your bicarbonate at start. So acidotic blood touching the filter causes bradykinin release. Anticoagulation, no change in the management of systemic anticoagulation. But for any reason, do not want to anticoagulate the patient on ECMO because that patient is bleeding and all, you can do regional citrate anticoagulation. Now, bedside, how do we know hemolysis? This is one of the most common complications. We do not have plasma-free hemoglobin. It's not easily available, plus the turnaround time. So carboxyhemoglobin does go up when we connect a CRRT, and this gives a clue even before it actually rises up, even before your LDH, etc. So even before your hemoglobinuria, you can see the carboxyhemoglobin rise. Remember, you'll have a falsely low anti-10A when there is hemolysis. Free hemoglobin is bad. It will worsen and cause ATN. So, you may have to change your filter and ensure that you don't have too much of hemolysis. Now, Dr. Nanda already spoke about, infections. Fever temperatures are misleading because you have the heater here. So unexplained low platelets, tachycardia, feed intolerance, and all should think of sepsis. And a lot of connections. So only the perfusionist. And be very careful because there's so many gadgetry. There can be some pull. There can be, circuit disconnections. Be very mindful and, keep it all well organized. Now, drug dosing. You have a lot of drugs. You have your sedatives, antihypertensives, antibiotics, all being extracorporeal. They get also sequestered in the ECMO circuit. Then they also get cleared by your CRRT. So please give full loading dose. You have to be mindful that a lot of it is also lost in the ECMO as well in the CRRT. So I would give full dose of antibiotics. You want a live child, even if the kidneys need some support, it's still okay, but you need to, conquer the infection. So message, avoid fluid overload on ECMO, institute early renal replacement therapy if you have acidosis or fluid overload, stubborn fluid overload, because delay can prove costly. Thank you.